Allora, va bene, buongiorno a tutti. Io sono Andrea Pugliese, intanto faccio due parole di presentazione in generale dell'iniziativa. Questo è il secondo dei seminari di cui vedete qua organizzato dal gruppo l'Unione Matematica Italiana, il gruppo MSE, che sta per Modellistica Socio-Epidemiologica, che appunto è nato l'anno scorso, raduna in questo momento direi una trentina di soci dell'Unione Matematica Italiana interessati appunto a questa problematica della modellistica in questo settore. Abbiamo organizzato questo ciclo di seminari e vedremo appunto di continuare con le attività. Se qualcuno di voi è interessato può scriverci o andare sulla pagina dei gruppi dell'UMI o scrivermi direttamente a me, Andrea Pugliese, dell'Università di Trento. E appunto questa è una delle iniziative che stiamo facendo, fra altre di tipo un po' divulgativo, e cerchiamo di tenere aggiornata una pagina web sull'iniziativa nel settore. Adesso, fra poco cominciamo col seminario della professoressa Giulia Giordano. Do la parola a Dimitri Breda perché faccia lui una breve presentazione del speaker. Ecco qua, per forza, Mattia Zanella ha mandato in chat qual è l'indirizzo della pagina web del gruppo, per cui se siete interessati potete andare lì e scriverci o vedere il materiale che c'è. Arrivederci e Dimitri, prego.
Grazie Andrea, buonasera a tutti. Ed è un particolare piacere questa sera presentarvi Giulia Giordano, che sarà la relatrice del secondo seminario. Un piacere particolare perché Giulia si è laureata all'Università di Udine, dove ha preso anche il dottorato in teoria dei sistemi e controllo, e dopo diversi periodi all'estero come visitor al California Institute of Technology, all'Università di Stuttgart. È stata anche postdoc all'Università di Lund e poi all'Università di Delft, e ora con il Dipartimento di Ingegneria Industriale dell'Università di Trento. Ecco, in tutto questo percorso, tutto sommato, sono passati anche pochi anni, diciamo. Giulia ha acquisito una notevole, direi, esperienza e nell'area generale della teoria dei sistemi, del controllo dei sistemi dinamici, e in particolare nel campo delle reti dinamiche e dell'approccio strutturale all'analisi dei sistemi biologici. Quindi con molto piacere che vi presento Giulia, e questa sera ci parlerà di varianti del Covid e dei relativi vaccini, con un messaggio, come potete vedere dal titolo, di particolare attenzione rispetto al contenimento dell'epidemia, che adesso sembra ancora più importante di un anno fa oramai. Giulia, grazie ancora e buona presentazione.
Grazie mille a te Dimitri per la presentazione e grazie a voi Dimitri e Andrea per l'invito. Sono molto contenta di essere qui con voi questo pomeriggio e presentarvi gli ultimi sviluppi del lavoro di cui mi sto occupando a tema epidemia, a tema Covid-19 in particolare. La presentazione in inglese o in italiano? Allora passo all'inglese oppure...
Ma sì, non lo so appunto. Non so se siamo tutti italiani qua, forse parla in inglese per sicurezza, se non è un problema.
Okay, then I'm switching to English for the presentation. And so thanks again to Dimitri for the introduction and to the organizers for inviting me to join this series of seminars. I'm very happy to be here with you this afternoon and present to you some recent work I've been doing with colleagues, both colleagues from with a mathematical modeling background and colleagues with a clinical perspective on epidemics and on COVID-19 in particular. And indeed, the special focus of this talk will be about the new key players that have recently appeared in the scenario in the fight against SARS-CoV-2, new variants, which are now confirmed to be much more transmissible. so much more dangerous than the original strain, and vaccines that are now available, and vaccine rollout has already started, and mass vaccination campaigns have already started in many different countries. So these are the new key elements, and it's important for us to understand whether these two new elements, which are having an opposite impact, so vaccines could be the solution, while variants are adding a new and extremely dangerous element to worry about. Well, in the interplay between these two new elements, what shall we do? Is it still important, and how much to contain the epidemic with non-pharmaceutical interventions at this stage? So this is the question that we are going to answer during the talk with a quantitative approach. And well, of course, I mean, I have nothing to teach to any of you here about predictive mathematical models for epidemics. There are a lot of them of many different types, and many of you, probably all of you in the audience, have contributed with their work to building some fundamental modeling approaches and new models to forecast the trend of epidemics, and to not only predict what's going to happen, but also enable through mathematical modeling the planning of effective strategies to control and suppress epidemics. And different models indeed can be built with this aim. The first ones, and from a certain point of view, the most basic ones, are mean field compartmental models, but there are also very complex and well-descriptive models that are based on underlying networks of contacts, and also stochastic transmission models. And in the last year, a huge amount of models of all of these three types have been developed, tailored in particular to the recent COVID-19 pandemic. And in particular, I'm going to focus here on one model that I've been working on, and that we have proposed, which belongs to the first class. So it's a mean field compartmental model, which we have tailored indeed to the specific features of COVID-19 in order to be able to understand how the epidemic was evolving, predict its future evolution, and also assess the effectiveness of implementing some population-wide interventions to fight the epidemic, with Italy as a special case study. So, well, this model is indeed, well, it's a simple compartmental model, just with the infected compartment that is subdivided into different categories. And indeed, the goal is to take into account the specific features of the COVID-19 epidemic, which are essentially, well, different patients, different infected subjects show a completely different outcome in terms of clinical evolution of the disease and different severity of illness. Some people are completely asymptomatic throughout the whole infection. Other people risk their life and die because of the very same infection. So there can be many different levels of severity of illness that have to be taken into account when we want to predict the expected levels of hospitalization and occupancy of intensive care units, for instance, and the case fatality rate. And also the fact that there is a huge pool of asymptomatic infected leads to a potential underestimation of the epidemic, because those infected are very hard to detect. They're invisible unless we trace them because they've come into contact with a known infected. It's very hard to understand that a completely asymptomatic person is infected, but this person is still infectious. So this huge pool of asymptomatic people still largely contribute to the spreading of the epidemic, even more because they've not been detected, so they don't know to be potentially spreading the infection around. So indeed, we have these 5 classes of infected. So a susceptible person, after having come into contact with any of these types of infected, so through contagion becomes at the first stage an asymptomatic infected, and of course is not detected at first. Then this asymptomatic infected can be detected through diagnosis, through a nasal swab typically, and becomes an asymptomatic infected who has been detected. So now this person is counted in the data about the epidemic. Well, regardless of whether one has been or has not been diagnosed, one can start developing clinically relevant symptoms. So we have symptomatic infected, which can be both, well, either undetected or detected. And we assume that also critical conditions indeed can be developed at a certain stage of the infection, which leads to the compartment of threatened people. So people who have such symptoms that they risk indeed their life because of the infection. And from this compartment, indeed, we can have, unfortunately, a flux of with a certain death probability. So we have the compartment of deaths, which we call the extinct compartment. And luckily, from all of these compartments, regardless of having been detected or not, and regardless of the severity of the maximum severity of the symptoms that have been developed, the infected can heal and can become indeed recovered. So this is the model. These are the equations. It's a very simple mean field compartmental model, which enjoys, of course, the mass conservation property, the sum of all the variables which we associate with the fraction of people of the population which belong to the specific compartment. Well, this sum is equal to 1, so it's preserved throughout the evolution of the system. It's a bilinear system, it's a positive system, so of course it's guaranteed that the variables will remain positive throughout the evolution of the system. And the compartments of healed people, so recovered people, and dead people can be seen as some outputs somehow of the model. So they are cumulative variables that do not influence the other variables, and they just depend on the other variables and on their own initial conditions. So the system admits, of course, equilibria, which are associated with empty infected compartments. So all the compartments of infected people are eventually emptied, and the sum of the asymptotic amount of susceptible, recovered, and dead people is going to be then equal to 1 at the equilibrium. We can see this system from a systems and control theory perspective. We are cursed with this habit of looking for feedback everywhere. And so we can be tempted to see this system as a feedback system. And indeed, we can see it as a positive linear system, which is the subsystem of the infected subtypes. And this positive linear system is subject to a feedback signal, which is the one that represents the infection, the possibility of the contact between a susceptible person and one of the infected types, which leads to contagion and to further spreading of the epidemic. So we can see that this closed loop is due to indeed an input that arrives to this positive linear system, which is due to the susceptible variable. And we have these 3 outputs, which are related to indeed recovered people, dead people, and to the susceptibles that they represent the variable that closes the loop. So these three variables are needed to compute the evolution of the amount of the fraction of susceptible people, recovered people, and dead people. So by looking at the system in this way, we can easily find a new definition of the, a definition of the basic reproduction number, which generalizes the classical one in the SIR compartmental system. It's slightly more complex, but again, it's simply dependent on the parameters of the system, which in this case, however, are quite many. So the expression is a bit more complicated, but it preserves all the properties that a classical R0 number has for the simplest possible compartmental model. So a larger value of R0 is associated with a stronger affection of the population. The epidemic is more aggressive, and a larger amount of people pass throughout contagion somehow. And the stability of the equilibrium is indeed guaranteed when the number of susceptibles, the eventual number of susceptibles multiplied by this R0 is less than 1. So this R0, this redefined R0 preserves all the classical features of the classic R0 in the SIR model. And if we want to keep stubbornly this feedback perspective, we can see that this R0 can be defined as the H infinity norm of the transfer function that goes from this input U in this feedback scheme to the output YS. So if we think of the transfer function that relates this input with this output, it's H infinity norm, which is the integral of the impulse response, and for a positive system can be simply computed as the value of the transfer function at 0. Well, this value is indeed identical to this definition of the basic reproduction number. So there's a nice control theoretic interpretation of it somehow. We can also explicitly compute the case fatality rate based on this model, and we can do it in this distinguishing between the actual case fatality rate and the perceived case fatality rate. So this model enables us to quantify somehow the amount of infected that have never been detected, because they are some of the state variables. And if we consider all the whole pool of infected, so we consider the sum of the population in all the 3 infected compartments, then we have the actual case fatality rate, where we take the ratio between fatalities and the total amount of infections, including the undetected ones. While if we consider just the perceived case fatality rate, well, we are comparing it with what we would infer from the data. So we consider only the categories of infected that would pop up in the statistics, those that have been detected and are counted. And through a simple integral equality, this one here, we can derive an explicit expression for these 2 quantities without having to compute the integrals, but just an expression that depends on the value of the state variables and on the initial conditions. So we can compare what is visible and what is not visible, what is hidden, what has never been, the amount of people that have never received a diagnosis, but still have been infected and have been infectious, so they've contributed to the spreading of the epidemic. And also the model is designed in such a way that we highlight which are the possible knobs that the decision maker can use for interventions. And very luckily, if we perform a sensitivity analysis for the parameters in this model, these parameters, which are the knobs upon which one could act, are the ones with high sensitivity. The sensitivity to all the other parameters is very small. So we are lucky in this respect. And well, these high sensitivity parameters, these knobs that we can act upon, are indeed the contagion parameters, which we can change through lockdowns, through physical distancing, through the use of personal protective equipment, through having seminars on Zoom instead of in person. And we have the diagnosis parameters, which have, of course, change dramatically if testing and contact tracing is performed in a massive way. So these are the knobs we could act upon, and it's interesting to look into the impact of the measures that we could take by acting on these knobs. So what is the impact, for instance, of physical distancing measures? Well, taking the Italian first outbreak as a case study, we see here the effect that we could have had by including no restrictions, and we see then the effect of mild physical distancing measures, mild restrictions. We see that they contribute a lot to reducing the size of the epidemic, even though they delay the peak. Strong restrictions instead are very, very effective in reducing the size of the epidemic. The scale on the y-axis is completely different. So if restrictions are strong enough, they can immediately stop the spreading of the epidemic. They can even anticipate the peak with respect to what we would have without restrictions. So, of course, restrictions are important, are useful, are effective. This is what we all know. But what about their interplay with testing and contact tracing? So, well, if we start a massive testing and contact tracing campaign, we can contribute to further reducing the spread of the epidemic. Of course, this is much more effective when there are low case numbers. Otherwise, the system to be put in place for testing and contact tracing is too large to be manageable. So, especially at low case numbers, testing and contact tracing is effective in further reducing the spread of the epidemic. And the fact that it requires low case numbers to work well indeed advocates for using it in combination with restrictions in terms of physical distancing and lockdown. So if we happen to be willing to weaken the lockdown, well, this could lead to dramatic outcomes, but if we have brought the epidemic to a small enough size and we combine this weakening of the lockdown with a massive campaign of testing and contact tracing, we can still weaken the lockdown in a safe way. So this would be the difference between, in a comparable situation, between at this point here, weakening the lockdown, which leads to a new surge in the number of infections, and weakening the lockdown, but enforcing massive testing and contact tracing. The epidemic is kept under control in spite of the reopening. So which are the main messages that we can infer through simulations and analysis of this model? Well, a prompt lockdown and physical distancing is crucial. Indeed, it has to be prompt. The more it is delayed, the less effective it is. It's very important. It is effective. And well, if we have distancing measures that are mild, then they delay the peak and they lead to just a moderate decrease in the number of infected. But if the measures, the distancing measures are very strong, they can even anticipate and they drastically reduce the peak in the number of infected. So it's important to act promptly and strongly. This is what actually, well, we know we've learned throughout this journey in the last year also. And the model emphasizes the potential strong benefits of testing and contact tracing when combined with distancing. And indeed, distancing, once the case numbers have been brought to low enough values, distancing can also be released, somehow be mitigated, provided that a massive testing and contact tracing system is kept working well. And indeed, if we look at the Italian case throughout 2020, this is what we see. So we had a first wave, and this first wave was quite effectively stopped by the lockdown in spring, which indeed matches well with the first message that we had learned early in the year through this model. A lockdown is needed, and it works, and indeed it worked. It worked very well. These plots show a comparison between the data in red and the predictions that we generated at that time through the Siddhartha model. And so these would be the infected with different severities of illness. We see that indeed the lockdown worked as it should. But then a second wave came, which led to a dramatic surge again in the number of infections that was even much higher than the previous one. And why this happened? Somehow, well, because of, we came back from the summer, so the school started again, so more contacts. But also it happened because, and it happened so dramatically somehow, because the testing and tracing system indeed collapsed. So the number of cases was slowly growing underneath, and the testing and contact tracing system was not able to keep track of that. And then we had, of course, the expected exponential explosion at a certain time. So we can see very well this effect of, well, the testing and contact tracing system that collapses in this plot here. That is an analysis based on the Siddhartha model of the evolution of the epidemic throughout the summer and in early autumn. And we see here what was happening according to the model prediction. So by fitting the data, so the observable variables, the ones associated with diagnosed, with detected infected, we were able to also indeed provide some estimate of the undetected infected. And we see that what happens throughout the summer and in autumn is that the fraction of undetected cases over the total number of infections is growing, which means indeed the testing and contact tracing system is not able to keep the pace, it's collapsing. And this is what led to the new huge surge in infections. This is the interpretation that we can give through the use through the lenses of the model. And this is the fit and a bit of prediction that we generated at that time using the Siddhartha model for the second wave. Indeed, a new surge in the amount of cases, but after that new surge was tamed with some, well, kind of intermittent, a bit shy lockdowns, not so strong interventions. The epidemic was kept at the level of, just preventing it to explode, but still at high levels of circulation of the virus. With the end of 2020, early 2021, we have finally we have some good news concerning the management of the epidemic. Finally, we have vaccines available, they've been approved, they've been testing, and we can start mass vaccination campaigns over the whole population. Well, good news, but in parallel, we start receiving some bad news that the virus has started massively mutating, and there are a bunch of variants. The UK Kent variant, the South African variant, the Brazilian variant, which show to be much more aggressive, perhaps even more lethal, but for sure much more transmissible. For instance, for the UK variant, the estimated range is about like 40-50%, 70% more transmissible than the original strain. So it's an alarming situation on the one hand, and on the other hand, we seem to have finally the weapon to solve the problem once and for all, which is even worse because indeed this gives us a kind of sense of false false safety. We think we're safe because the first vaccine doses have been injected, have been distributed. But actually, we will be safe when all of them will have been injected, and when all the second doses will have been injected, provided that no vaccine-resistant variant appears in the meantime. So we have these new key players that could potentially disruptively change the scenario. What shall we do with this? So, well, we to investigate this aspect, we slightly modify the Siddhartha model. We include a new knob to intervene, to act on the epidemic with strategic decision making somehow, and this is the possibility of vaccinating and then immunizing people at a certain speed, which depends on vaccine rollout, and well, first and foremost, it depends on vaccine availability, because well, before organizing logistics, you need to have them, and you need those who produce them to give them to you timely. So it's a big question mark how fast this can be done. And this Siddhartha V model, which includes vaccination, so the new compartment of vaccinated, which we interpret as successfully immunized people. So those who receive the vaccine, but the vaccine is not effective, they remain in the susceptible compartment. So they're still at risk of getting infected and going through all the risks of the infection. So successfully immunized people after receiving the vaccine become, of course, safe from, hopefully from contagion, and for sure from the risk of serious disease and death. And we use this modified model to predict the amount of daily new cases, but then to generate some predictions about the healthcare system costs, and in particular, indeed, number of deaths, number of intensive care unit occupancy, and number of hospitalized cases in normal wards, so generic hospital occupancy, or to generate, to project the daily new cases onto these three metrics of these three costs. We use a data-driven model of health costs. And our observations are somehow summarized in this figure here. So here we see the effect of different levels of countermeasures, which are associated with the different curves. And we see on the x-axis the effect of a different vaccination speed. So we see here the fraction of population, the percentage of population that we expect to have vaccinated within January 2022. And it's very immediate to see that, especially if the virus circulation can be brought to low enough levels. So this would be the case of a new R0, let's say, that is 0.9, so below 1. Vaccinating fast or slowly makes essentially no difference. If we have an average, let's say, slightly above 1 R0, then vaccinating at a higher speed leads to some considerable somehow advantage. And even more if the virus transmission is very high. So if we have some R0 around 1.3, the effect of faster vaccination is visible, is consistent somehow with what we expect. But what we can notice is that the impact of vaccinating at a higher speed, the impact of vaccination in general, is much smaller, especially, of course, in the first phases, than the effect of introducing restrictions that reduce the virus, the virus spread. So, well, the difference in the expected total deaths over the whole next year is very, very large if we think of reducing R0 from 1.3 to 0.9, or well, at least 1.1, there's a very large difference, and this difference is much larger than what we could obtain by vaccinating even at a fast speed. So, well, we get to these conclusions through this model that is indeed a kind of layered model. It has two stages. The first one is the usual old dear Siddhartha model with those new elements given by the presence of the vaccination term and of the vaccinated compartment. Again, vaccinated means immunized, actually, successfully immunized. And we split the death probability. Somehow we take into account the fact that people, and this is made to better fit the data, actually. So in practice, people could die before they reach an intensive care unit, so they would not be recorded in the data in the list of people that have gone through an intensive care unit, even though they would have needed it, actually. And to fix this, we introduce a possible flow of death that starts from the symptomatic detected infected and not just from the threatened infected. So these are small changes, but the model preserves all the properties essentially that I've gone through before. So it's the very same model with a small change. Well, we have vaccinated people now into the picture, and of course, assuming that immunity lasts forever, if we think of the equilibria of the system here, the difference would be that the equilibrium, the susceptible compartment would be empty, as well as all the infected compartments, and the vaccinated plus healed plus extinct compartments would sum up to 1 at the equilibrium. But since we know that immunity is not going to last forever, it's pointless to ask about the asymptotic value of the state in this situation, in this scenario. And what about the second part of the model? So this second part of the model, it receives the number of new positive cases from the Siddhartha V model, and it projects it onto the healthcare system costs. Well, first of all, so this term here that depicts the speed of vaccination rollout somehow and distribution, the speed of the vaccination campaign needs to be indeed determined according to some profiles that are hopefully matching what is planned to do by the authorities. So we are going to use some profiles with this vaccination speed that is going to be constant, piecewise constant somehow according to the expected speed of the vaccination campaigns, and we're going to consider possible different scenarios. So to get there, we consider a possible vaccination roadmap. So this is the fraction of people who have not, the percentage of people who have not been vaccinated yet. So we assume this piecewise constant rate of vaccination, of immunization to be precise. So this would be a possible vaccination roadmap. The compartmental model does not take age classes into account, but to take them into account, well, we do it now with the second part of the model, with this database model. We associate this vaccination roadmap with the knowledge that, at least in Italy, vaccination has been is planned and is being performed by giving priority to the elderly. So we take into account demographic information about the population. So we see here the cumulative population with respect to age. And we take into account how the case fatality rate is going to vary, taking into account indeed the statistics about the population and the demographics of the Italian population. And we can then build a case fatality rate with respect to age based on statistics on the different case fatality rate in different age classes for COVID-19. And based on this overall elaboration of data, we can build an expected evolution of the overall case fatality rate over time associated with this vaccination roadmap, with this vaccination profile over time. And we use this, indeed, in association with possible different profiles of vaccination, of immunization, again, to be precise. So a fast, a medium, a slow vaccination profile, where the vaccination rate is indeed taken as piecewise constant, and this is the evolution of the cumulative percentage of vaccinated people. This would be the fast case, and this corresponds to a certain time evolution of the case fatality rate. And based on this assessment that takes into account indeed data on the epidemics and data on the demographic structure of the population, we get to a data-based dynamic input-output model, actually 3 different models that project the daily new cases, the new infected, onto healthcare system costs in terms of deaths that we can expect, hospital occupancy, and intensive care unit occupancy. So these three input-output models are somehow associated with the 3 categories of visible, of detected infected that we consider in the Siddhartha model, and they are associated indeed with the needs of the hospital and of the healthcare system in planning how many beds will be needed, how many ICU units will be needed, and how many deaths we can expect. So the costs that we are going to pay in terms of what are, I mean, the life that the epidemic will take. And based on this model, this 2-stage model, we are going to investigate the effect of restrictions and of vaccination in a combined fashion. So what are we doing? First, well, we consider the impact, let's say, as a starting point without vaccination, the impact of different transmission rates. So we have the variants, right? So the type of restrictions that enabled us to survive with an RT that was around 1 all the time, with the original strain, is no longer sufficient at all to remain around 1 when we have an increased transmissibility of at least 40%. So in this type of scenarios, we consider 3 possible outcomes, indeed, in terms of the new R, depending on an interplay between the higher transmissibility of the variants and possibly more stringent restrictions. So we span from, so this first case study, let's say with an R0 that is less than 1, which would lead to, so it would be associated, given that indeed higher transmissibility variants are now becoming the dominant ones in Italy. To get there, we would need draconian restrictions, and they would still enable full control of the epidemic, a decrease to 0 of the number of infections and of hospitalizations and of deaths. The other scenario is with an R0 that is slightly above 1, which could be indeed achieved through strong but not draconian restrictions, and taking into account a much higher transmissibility due to the variants. And the other scenario is with an R0 that is around 1.3 and would be associated with poor control of the increased transmissibility of the variants. So like keeping things as they are under the optimistic assumption that the increased transmissibility of the variant is only of like 30-40% and not of 70%. So a bit of a risky approach, keeping things as they are and hoping that the UK variant is not that much more transmissible. And this is what would happen, actually, indeed, the dramatic surge in the number of cases, in hospital occupancy, in ICU occupancy, and in deaths. So this is not what we want. While with strong enough restrictions, even without vaccination, so as to get at least to an R0 around 1.1, we would be able to keep the epidemic under control and have less daily deaths than in the second wave, for instance. And of course, I mean, if we bring it to 0.1, then we have that the epidemic is reabsorbing, let's say, spontaneously. But that's hard to get. And well, if we introduce vaccination into the picture, well, the behavior is quite similar, but note the different scale. So here we have like 140,000, and here it's 90,000. So we have a reduction, which is not that much impressive if we think of the difference between these curves here. So indeed, as I was mentioning before, the effect of restrictions is much larger than the effect of vaccination. If we introduce vaccination into the picture, of course, we improve the situation, but introducing restrictions that bring R0 closer to 1 from above makes things much, much better than a vaccination campaign. And here we are considering the medium speed vaccination profile, but as we will see, there's not much difference between the various scenarios in terms of how fast the vaccination is. The effect is not that different. And well, what we are probably ending up doing, given what we have seen in the previous months, is we are going to be faced with intermittent epidemic control strategies. So we have seen in Italy, as much as in many other countries, for instance, Israel, but also many others, well, the UK, an alternation between opening phases where mobility restrictions and lockdowns were lifted or were eased a lot, and phases when hard restrictions, or at least harder restrictions, were enforced. And these two attitudes somehow were alternating. So there was an intermittent, there were intermittent strategies, let's say, in controlling the epidemic. And well, what these two figures show us is that as it is intuitive, actually, if we decide that we want to alternate some opening phases and some closing phases, we'd better start with the closing phase, because this leads to a huge reduction in healthcare system costs. We can assume reasonably that the costs that we have to pay in terms of how many people die, how many people will be hospitalized, how many people will get infected and suffer from long COVID issues, well, this cost is proportional to the integral of the curve of active cases. So if we open first, if we start from the very same level, the same size of the epidemic, and we open first, so we allow the epidemic to increase asymptotically in an exponential fashion, then we are going to have a huge surge in cases. And then at a certain point, we stop this exponential growth. We decide that we have to close, and we bring it back to the level that it had before. So in this process, we have had a huge number of cases, that will lead to a huge number of hospitalizations, of deaths, of long COVID consequences. While if we start from the very same point, and so like we bring time back somehow, and we say, well, if we had started back then with closing, what could have happened? Well, we start from the very same level of the epidemic. We close, and we allow ourselves to close in this hypothetical experiment. We allow ourselves to close at the same level of stringency that was adopted here to bring the epidemic back to the initial level, and for the same amount of time. So same stringency, same amount of time. And we can assume reasonably that the socio-economic cost that we have to bear for this closure depends exclusively, essentially, on how stringent the closure is and how long it lasts. So the cost we have to pay in terms of socioeconomic issues, socioeconomic losses, is identical in this second scenario. It's exactly the same as it is in this one. But so we close for the same amount of time and with the same stringency. We open for the same amount of time and with the same easiness as in this first case. But now we are swapping the two interventions in time. So first we close, we get to a much lower size of the epidemic, then we open again and we allow the epidemic to go back to the same level it had before. It can be computed that indeed with these timings and assuming an exponential growth, this is going to happen. So these three levels are going to be the very same. So by procrastinating, indeed, as this title suggests, so procrastination leads us to pay a heavy toll. A preemptive strategy where we open later and we start with closing. So closing first saves lives and essentially does not increase socioeconomic costs. So why shouldn't we do it? So since we know that we are going to have to close at a certain moment, it's mathematically proven that it's better to close first, because indeed we can, I mean, as a rule of thumb, the socioeconomic cost is not going to increase, but the costs that we have to pay in terms of healthcare costs, and people suffering and dying, is dramatically reduced. And by taking into account this, we can input these two strategies into our vaccination variant scenario. So now let's see what's the difference with the Italian scenario between different intermittent strategies. So either first open then close, or first close then open. And these are the trajectories that we would get. Of course, I mean, first opening and then closing leads to much higher peaks in everything: daily infected, hospital occupancy, ICU occupancy, daily deaths. While closing first, well, throughout this time span leads to essentially the same socioeconomic costs, but we see that it keeps the epidemic at a much lower level. And this is without vaccination. If now we include vaccination into the picture, we see that the difference is not that big. This is medium speed vaccination still. The big impact, the big reduction here in the number of cases and the consequent healthcare costs is given by a wiser strategy, much more than by a reasonably fast vaccination campaign. And this is indeed the impact of different vaccination speeds, provided that, so let's say we adopt the open-close strategy. By the way, these plots have been generated 1 month ago. And so these are the data which match, of course, the model has been fitted to the data. So the model reproduces the data up to this point, and then the prediction starts. And if we could add the new data released during this last month here, they would exactly track this surge that is predicted by the open-close scenario. So what we are doing now is we are following the open-close hopefully. So at the moment it's the open phase, but probably we're going to close soon before we get to such a surge. But the scenario, I mean, what is happening currently is pretty much aligned with this open or open-close, hopefully, scenario here. And we see that indeed a wiser strategy would make a big difference. But once we have decided to choose the less wise strategy, and we are opening first, we are letting everything open, and we are going to close only when the hospitals will be saturated and the ICU beds will be full and so on, instead of taking a preemptive, wiser approach. Well, if we choose to do this, if this is the strategy, and we see what could be the effect of a faster vaccination campaign, we see that in particular in the initial phases, the difference is very, very small. So no vaccination campaign that is reasonably fast, because of course, I mean, if we assume an infinite speed of vaccination, so we assume to vaccinate all the people in a couple of days, the whole population of the country, then okay, well, this could make a different impact, but no vaccination campaign at a reasonably fast speed and at an achievable speed could really make the difference at this stage, which advocates for NPIs, for non-pharmaceutical interventions to tame the epidemic in the first phase, and only when a large enough amount of population will have been vaccinated and successfully immunized, those restrictions will be possibly released without leading to dramatic outcomes. So these are indeed the messages that we can extract from the predictions and the simulation obtained through this two-layer Siddhartha vaccine and data-driven model of the COVID-19 epidemic. There's the important risk that, well, it's not a risk, it's certain that variants have the potential, and they are bringing the epidemic out of control due to their much higher transmissibility. And vaccination only is not sufficient to keep the epidemic under control. We need non-pharmaceutical interventions, at least in the first phase, because in the first phase, with such a high viral circulation as the one we're having at this moment, non-pharmaceutical interventions have a much larger impact on reducing the epidemic size than vaccination, than any arbitrarily fast, reasonably fast vaccination campaign. So the strong advice that comes out of the predictions, the quantitative analysis with this model, is that containment measures should be kept in place throughout the vaccination campaign, at least in the first phases. Then once a sufficiently large amount of population will have been vaccinated, so once sufficient population immunity has been reached, at least the more fragile categories have been protected and vaccinated, at that point we will be able to slowly, gradually release NPIs, non-pharmaceutical interventions, in a safe enough fashion. And the other strong message that comes out of this model is that, well, if you really want to adopt some intermittent measures that alternate opening phases with closing phases, starting with an open phase and then leaving everything open, waiting for the healthcare system to collapse and then just closing at that moment, or closing to keep the size of the epidemic small and then opening once you've reached a sufficiently low amount of cases around. Well, these two approaches are not equivalent. They lead to a dramatically different outcome in terms of healthcare system costs. However, if we assume that the duration of the strong restrictions and their stringency is the same in the two cases, we have no difference in terms of socioeconomic costs. So by waiting until the hospitals are full, we are simply aggravating the situation from an healthcare perspective without any kind of gain in terms of socioeconomic reduction of socioeconomic losses. Because at a certain point, when the hospitals collapse, we will be forced to close with the same stringency and with the same duration that we could have adopted with a preemptive approach. So there's an optimal strategy, which is the ones that politicians tend to avoid for some reason. This is the summary, let's say, of the messages that we can get through this model that we have proposed with colleagues in this draft, in this preprint that you can find on arXiv. Let me thank the people with whom indeed I've worked on these topics for their fruitful collaboration, and let me thank you very much for your attention and your patience. Thanks a lot. Grazie.
Grazie Giulia per la talk molto interessante, and direi che c'è tempo per fare domande. Direi che chi vuole intervenire magari dice lo metto sulla chat, così chiamo chi è che vuole parlare, forse è la cosa più semplice. Okay, in the meantime, Okay, Laura, per piacere. Laura, you can speak.
Oh, thank you. So I have a question for Giulia. Thank you for your talk. Can you hear me well?
Yes, I can hear you well.
Oh, I have a question about the construction of the model. How did you include the variance? So is it a multi-strain model with explicit compartments, or did you include the variance implicitly with a change in the force of infection?
The second one. So as you see, I mean, these are the stages, and we are not making any difference between getting infected with one variant or with the other. We are considering in an implicit way the effect of different variants. We assume that indeed, depending on the proportion of each of the variants that we have circulating at the moment, and depending on the different transmissibility of these variants, we are going to determine the contagion parameters accordingly. So they are time varying. We can typically, well, they're piecewise constant. So well, we change them at certain times to keep track of what's going on, of changes in the evolution of the situation in terms of restrictions, but also indeed in terms of we can adapt them to track the increased average transmissibility due to the presence of variants. So we are taking into account variants, but in an explicit way, without adding even more compartments to the model. It's not a multi-strain model, it's implicit.
Okay, thank you. And the percentage of cases infected with a variant, you inform that from data that you have, or?
Yes, indeed. I mean, the increased transmissibility is determined based on data available in the literature and based on the estimates about the increased transmissibility. For instance, for the UK Kent variant. So we are lumping, let's say, two things together, because of course these contagion parameters depend both on the intrinsic transmissibility of the strain that we're and of the variant that we're considering, and on the restrictions. Because I mean, if we have a more transmissible variant, but we have very tight and stringent restrictions, then these two effects could cancel out, let's say, and we could keep the old contagion parameters the same that we would have for a less transmissible variant, but with no restrictions, for instance. So these two effects are combined together in the contagion parameters and in the resulting R, initial R that we are determining. So the idea would be, okay, well, it's a kind of rule of thumb. Let's say, well, if in the literature they say that this variant is like 50% more transmissible, then we increase this parameter of 50%. But then if we make the restrictions more stringent, then we reduce this parameter a bit to take that into account. So this is how the hypothetic scenarios are built. And then, of course, by fitting the new data, we can understand whether these contagion parameters are actually exploding due to the new variant, or maybe are kept a bit under control because of additional restrictions. I don't know if this answers your question.
Yes, thank you very much. Thank you.
Thanks to you.
Okay, I have seen that Mr. Nicola Parolini raising hand. So please, Nicola.
Thank you, Andrea. Thank you very much for the very nice and interesting talk. I have just a request, if you can elaborate a little bit more on the way you account for the age difference in the vaccination campaign when you change your model in order to take into account it in a model where there is no age compartment.
Okay, so well, we are not taking into account age classes in the first stage of the model. So here it's a classical mean field compartmental model at this stage. So all the age classes are mixed here to generate the expected number of new cases. And indeed, I mean, there's no reason to think that people with different age are differently susceptible somehow. So we generate daily new cases in a totally mixed fashion. At that point, to project those daily new cases onto casualties, onto hospitalizations, and so on, we take into account the fact that the case fatality rate, thanks to the vaccination campaign, is going to change over time. And how do we make it vary over time? Well, we take into account not only the speed at which vaccine rollout is occurring, but also we take into account the fact that we assume to start by vaccinating the elderly. We take into account, well, how many they are. So we take into account the cumulative population distribution with respect to age. And we build, in this way, we build by taking into account the different case fatality rates that have been observed in the data about this specific epidemic. We know that classes of the elderly show a much higher, unfortunately, case fatality rate. So we say, well, the case fatality rate as a function of the population has this shape. If we start by vaccinating the elderly, so in the first period we vaccinate the elderly, the overall case fatality rate is going to decrease at a certain rate. So for instance, as you can see here, the vaccination roadmap in this phase is proceeding very, very slowly, as it happened actually. So vaccine rollout is very, very slow in this phase. However, in spite of this, the overall case fatality rate is dropping very fast. And this is because we assume that people in this age span have been vaccinated. So the most fragile people have been put in a safe condition. And this has reduced the expected average case fatality rate a lot. Here we are vaccinating at a very fast speed, and in comparison, the reduction of the case fatality rate is very small if you think of the very different rate at which the vaccine rollout is going on. And this is because indeed the case fatality rate in other segments of the population, in younger segments of the population, is not that large. So this is how we are taking into account age classes. We make the case fatality, when we are projecting the number of infected onto expected hospitalizations, ICU hospitalizations, and deaths, in this data-driven input-output model that takes new infected and computes the expected deaths out of these infected, we use this case fatality rate. So we use a case fatality rate that varies over time, that decreases over time, taking into account a stronger decrease in the initial phases thanks to vaccination, because we assume that the elderly are being vaccinated. I don't know if this answers your question sufficiently well.
Yeah, thank you very much.
Thanks a lot to you.
Next, a question by Mattia. So please, Mattia.
So thank you, Giulia, for your nice seminar. I have a question actually. So I noticed that in your model, there is no presence of exposed, and in many other models, I mean, many other people include the exposed compartment. So is this compartment really necessary in your opinion or not?
Well, I think it's not really necessary. I mean, if you want to provide an even more accurate description of the evolution of the disease, yeah, we know that there's a phase which is, however, quite short. I mean, it's a matter of days. It's not a matter of weeks. A phase in which one has gotten infected but is not yet infectious. But this phase is very, very short comparably with other types of disease. And the effect of it could be seen just as, I mean, a time shift in the curves, essentially. So instead of, I mean, the effect, I think, is quite modest in this particular context. So we can live without including one more compartment. It's not entirely accurate from a certain point of view, because it's not representing precisely the actual evolution of the disease. There's a short exposed phase, but I think that, I mean, given the fact that the model is already quite complex, I think that the added value of including yet another compartment with the exposed class is not that strong, let's say, to justify the increased complexity at this stage. Indeed, for sure, I mean, it would be justified to include it, for sure. I mean, from the point of view of the evolution of the disease. But this exposed phase is so short, and we can just, let's say, assume that we jumped enough. I mean, we replaced this delay, let's say, in moving from the S compartment to the I compartment, as like we incorporate this delay somehow in a different speed, in a different transmission parameter, and the effect is negligible, the effect of making this maybe not really orthodox approximation.
Okay, thank you.
Thank you.
Okay, I see no other questions, but maybe I also have a couple of questions myself, Giulia. Well, thanks for the talk, it was quite interesting. Well, going on what Nicola asked and seeing the decrease of case fatality rate versus time, I understand that vaccination has a speed of vaccination has very little effect on the infected cases, but wouldn't it have some effect on death rate, because you would go more quickly or less quickly in this in the decrease of case fatality rate?
Yes, I mean, yeah, from that point of view.
I didn't see that very much data in your graphs.
Yes, sorry?
Yeah, I didn't see that very well when you showed the effect of vaccination. I understand there is no effect on active cases, but perhaps it's much larger.
Yeah, but so probably, I mean, the different vaccination speed is, so let's say we assumed that the vaccination rate in the first period is more or less the same in the different scenarios.
Okay.
Because it's like what we can expect given the vaccine doses that we have already received, and not that many are going to be received in time to vaccinate massively in the upcoming like month, most likely. So, and here there is a delay included in this curve, because we are representing actually not vaccine injection, but we're representing immunization. So the people here are the ones that have received 2 doses of the vaccine, and that famous like couple of weeks, month has passed, so they are completely immunized. So there's some delay in the process. It would be hard to reach much larger fractions of vaccinated people in this short horizon. So the first part of the curve is more or less the same in the 3 strategies, and then the strategy is, I mean, the faster strategy shows its differences more in this second segment with respect to the others. And this is the reason why actually we don't see, if we compare different vaccination speeds here, we see almost no difference in this first phase between a slow and a fast vaccination, while the effect starts to be visible at a later stage. So let's say, in principle, if we could, it's true, if we could be much faster in this first phase, there would be probably not that big difference in terms of transmission, but there would be a much more visible difference in terms of that. And this can also be seen here. So the daily new cases, I mean, there's a quite of a small difference in this plot here, but the difference in daily deaths is much more pronounced, of course, relative to the size of the curve itself. So the impact on transmission is much smaller than the impact on death. So already in the first stage, thanks to the fact that we are protecting the elderly somehow, which are more at risk. And indeed, I mean, making the vaccination campaign faster makes a difference, even in the early stages. Our argument is that this difference is small compared with the difference that we could achieve with more stringent NPIs, with more stringent non-pharmaceutical interventions. And so this is why we think it's wise to join increased non-pharmaceutical interventions with the vaccine rollout, especially in the first phase, to kind of protect the vaccination campaign. And this would help prevent also the spread of new variants that could be potentially, and the appearance of new variants that could be potentially vaccine resistant. So especially in this first phase with a relatively slow vaccination campaign, and also if it could be faster, still, we think it would be advisable to keep viral circulation low in this state to enable doctors to be free to vaccinate instead of being in ICUs, to prevent, to avoid the risk of the appearance of new variants that could be even vaccine resistant, and because indeed a small increase in the stringency of non-pharmaceutical interventions has a larger impact than making the vaccine campaign much faster. So we think, I mean, it's important to do both, of course.
Okay, I see that Nicola has raised its hand another time.
If there is time for another question, otherwise.
Okay,
Sure.
Nicola.
I'm just curious about one aspect regarding forecast. If I understood correctly, when you look at a later time than today, let's say, you are going to consider different scenarios modifying the R0. But since your R0 in your model depends on most of the parameters, how do you actually change the R0? You act on just one part of the one, maybe the transmission rate, and
Exactly.
do you use the let's say the last value that you found in the calibration to modify it for later stage, or you adopt some strategy in order to let's say forecast how the parameter will evolve?
So yeah, exactly as in one of the scenarios that you've outlined. So what we're doing is we fix the most hidden parameters, such as well the rate of diagnosis, the rate of aggravation of symptom development, of developing of critical symptoms, risk of death, likelihood of recovery. These are kind of intrinsic parameters of the disease somehow. So we cannot expect them to change due to restrictions. So we estimate those parameters based on the historical data about the evolution of the model. And what we are going to change to show is indeed contagion parameters. And we assume indeed, well, there's no evidence that the variants are more lethal, so we have no reason to increase those death probabilities, for instance, at the moment. For sure, they're more transmissible, so they're going to, if a new variant, a more transmissible variant spreads, we need to change these parameters here to keep track of this fact. And analogously, if we introduce restrictions, they would be affecting the rate at which contagion can occur. So these are the only parameters that we allow ourselves to modify to create the different scenarios. The other ones are all determined based on historical data.
Sorry, but when in the forecast you include the vaccination campaign, in that case, I guess that the vaccination would impact also other parameters, because
no, well,
depending
this
on...
it's the phi parameter here. So the vaccination rate, the vaccination profile is associated with this parameter here. Yeah, this also we are changing the different scenarios with different vaccination profiles. Yes, but the other parameters of like the old Siddhartha model, let's say, are kept unchanged. So the different vaccination profiles impact on how this parameter here changes over time, and different parameters in terms of different interventions and spread of more transmissible viral strains are related to updating the contagion parameters here.
Because in some way I would have expected that since the vaccination campaign is strongly age depending, also the parameters that drive the...
There's a misunderstanding probably here. So this model here is used in our analysis just to generate the amount of daily new infections. And then the projections of these daily new infections onto healthcare system costs, including deaths, is done through this other stage of the model, which is the data-driven model. And this black box model includes the case fatality rate curve that is adjusted based on considering also age classes.
Okay, perfect. Thank you very much.
You're welcome.
Okay, there is another question by Fabio Bagaggiola. Please, Fabio.
Thank you, Giulia, for your talk. I have a question about the open-close strategy. that you show in one of the last slides. So maybe I missed something. The 2 times T0 and Tc are a priori chosen, or they depend on the state or something else?
Well, they're generic times. So we are comparing 2 situations where we first open for a time TO, and then we close for a time TC. And then we can prove that. So the underlying model here that we use is a simple exponential growth, exponential decay model, essentially. So it's not the Siddhartha model. It's not a complex compartmental model. We're just assuming that we have an exponential increase, let's say, with a certain rate when we open, and an exponential decrease at a certain rate when we close. So if you do the math, you see in the end that if you open for TO and then you close for TC, chosen in such a way that you go back to the initial level. And then if you swap them, so if you close for TC and then you open for TO, this equally ensures that you go back to the initial level. So in both cases, well, once you've chosen TO and TC in such a way that you start from point P and you end up at point Q, which is at the very same level as P, then if you start from point Q and you open for TC, you close for TC and then you open for TO, then you get to a point that is again at the very same level. So once you choose TO and TC to fit well, let's say the first scenario, swapping them leads to the very same outcome, that the final size of the epidemic is identical to the starting one.
Excuse me, on the y-axis, what do you have in this graph?
You have active cases. I don't know if because I see also your pictures on the screen. I don't know if I'm sharing just the slide or also your pictures.
Yeah, we see the pictures on screen.
Oh. Well,
okay.
Okay.
So yeah, so I was covering the label probably with the pictures, but so active cases is it's the amount of infected.
Okay.
That's the
label. You open, you close when you reach the same level, 20,000.
So let's say you start at any possible number of active cases. You open for a certain time TO, and then you close for a certain time TC, such that you end up at the same level where you started from.
Okay, but it is not ensured in general that in the blue region you have the same length on the time interval, right?
Well, if you assume the same rate of decay and of growth and you do the calculation, actually you get the same property. Once you fix the TC and TO to satisfy the property, let's say in the first scenario, it should turn out to be granted, let's say in the second scenario as well.
Okay.
Just so of course with a
when you start also the derivative of the curve may be relevant for the side.
Yes, it's because we are assuming an exponential growth with suitable, yeah.
So you are in the increasing case when you have to take the decision.
Sorry?
So you are assuming that you are in the increasing case when you have to take the decision.
Oh, well, no, it can be, I mean, you can determine, like you close for TC and then you let it open for a TO such that you go back to, you grow back to the initial value, and then the same TC-TO pair would lead to the same property of, like, you get back to the previous value also if you swap the order of the two operations, let's say.
Okay, thank you very much.
You're welcome, thank you.
Ok, non vedo altre domande, mi sembra che siano le 6:30, per cui se non c'è qualcuno che ha proprio una domanda limite, direi che mi sembra che possiamo ringraziare Giulia per il suo seminario, che è stato molto interessante, molte domande, e grazie ancora da parte di tutti noi. Ricordo che il prossimo seminario sarà fra 2 settimane, quindi il 25 marzo, da parte di Vauchelet dell'Università di Parigi, non mi ricordo il numero. E per cui vi invito a essere presenti anche fra 2 settimane a questo seminario. E dovete comunque mandare un messaggio e entrare sul sito che ha già scritto prima, adesso lo copio sul sito qua per copiare, così metto a tutti, così vi ricordate se è quello che serve per partecipare. Scusate. E grazie ancora Giulia e grazie a tutti per la partecipazione. Buona serata, nice night. Grazie Giulia ancora.
Grazie mille a voi per l'invito, è stato un piacere. Buona serata a tutti.
Grazie Giulia, ciao. Ciao
Grazie
a tutti.
Dimitri, ciao.
Ciao Giulia, da Rossana.
Ciao Rossana.
Ciao.
Buona serata, ciao.
Grazie, ciao.